Good morning, everyone. I'm Dr. Thomas Baudet, and I'm thrilled to be sharing with you today a comprehensive guide to cranial nerve examination. This journey will take us through each nerve, from the delicate sense of smell to the powerful muscles of the tongue, highlighting the unique role each plays in the intricate symphony of human neurological function. So, let's dive in and explore the fascinating world of cranial nerves. 1. The olfactory nerve, a tale of scents. Imagine walking into a bakery, the aroma of freshly baked bread filling your senses. This delightful experience is all thanks to the olfactory nerve, the first cranial nerve, which governs our sense of smell. Today, we'll be testing this crucial pathway through a simple yet insightful method. First, we'll ensure the patient's nasal passages are clear by having them breathe in through one nostril while the other is compressed. This simple maneuver ensures an unobstructed pathway for the scents we'll be introducing. Then, with the patient's eyes closed and one nostril occluded, we'll gently place a familiar scent, like cloves, coffee, soap, or vanilla, beneath the open nostril. Now, here's the twist. We'll be using at least 2 scents per nostril to ensure a comprehensive evaluation. Remember, it's crucial to avoid using any noxious substances, allergens, or any legal or illegal drugs which might accidentally stimulate the trigeminal nerve. A patient's inability to identify these scents, or their inability to smell anything at all, might signal an olfactory nerve dysfunction. A unilateral anosmia, or loss of smell on one side, might indicate a lesion affecting that particular olfactory nerve. On the other hand, bilateral anosmia, affecting both sides, could be a sign of sinus conditions, head trauma, drug use, or even the natural aging process, just to name a few. 2. The optic nerve, a window into the visual world. Next, we journey to the optic nerve, the second cranial nerve, responsible for transmitting visual information from the eye to the brain. This visual highway plays a pivotal role in our perception of the world around us. We'll assess the optic nerve through a series of tests, each providing a unique window into its functionality. Snellen eye chart. This familiar chart, with its rows of letters decreasing in size, allows us to measure the patient's visual acuity, revealing any potential limitations in their ability to see at a distance. This test, like many of the others we'll be performing, is best understood by referencing the ophthalmoscopy lecture. Confrontation. This test, again covered in our ophthalmoscopy lecture, is a more practical method of evaluating a patient's peripheral vision. Using our own vision as a reference point, we can compare our visual fields to the patient's. Ophthalmoscopy. This exam, utilizing the ophthalmoscope, allows us to visualize the fundus or back of the eye. This detailed view of the optic disc, blood vessels, and retina can reveal important information about the health of the optic nerve and the eye as a whole. Remember, this is one of those topics that could be addressed in another lecture, right? Just kidding. Maybe. 3. Pupillary light reflexes, the pupil's dance of light. The pupil, the black center of our eyes, is much more than a mere opening. It plays a vital role in regulating the amount of light entering the eye. This intricate process, known as the pupillary light reflex, is a testament to the coordinated dance between the optic and oculomotor nerves. To assess this reflex, we'll ask the patient to place their hand in front of their nose and keep their head still. This ensures their eyes are facing forward, allowing for a clear observation of pupillary responses. With the light source turned on, we'll gently shine the light into the uninvolved eye, observing for direct pupillary constriction, a normal reaction to the light. Then, we'll shine the light again, this time observing the opposite eye for consensual pupillary constriction, the simultaneous constriction of the other pupil, a fascinating example of the intricate interconnectedness of the nervous system. We'll repeat this process bilaterally. Here's where things get interesting. A dilated pupil that fails to constrict or constricts sluggishly can signal a problem with the optic or oculomotor nerve. For example, if we see a loss of both direct and consensual reflexes on the right, it suggests a lesion affecting the right optic nerve, leading to blindness. On the other hand, if the direct reflex is lost on the right, but the consensual reflex is present on the left, it points towards a lesion involving the right oculomotor nerve. 4. Cardinal fields of gaze, the symphony of eye movements. The smooth, coordinated movements of our eyes are a testament to the intricate collaboration of three cranial nerves, the oculomotor, trochlear, and abducens nerves. Together, they orchestrate the complex dance of our eye movements, allowing us to focus on objects in our visual field. To evaluate this intricate choreography, we'll ask the patient to follow our finger or pen as we move it in a wide H or star pattern, leading their gaze through 6 key directions: right, right and up, right and down, left, left and up, and left and down. Throughout this test, we'll be carefully observing the patient's eyes for any signs of asymmetry or irregularities, like nystagmus, a fine rhythmic oscillation of the eyes, or strabismus, where one eye is unable to follow the movement. An asymmetric eye motion, where one side moves differently from the other, can indicate a lesion affecting one of these crucial nerves. For instance, if the left eye fails to move to the left, it suggests a lesion affecting the left abducens nerve, the nerve responsible for lateral eye movement. Similarly, if the left eye fails to move right and down, it could be a sign of a left trochlear nerve lesion responsible for downward and inward eye movement. The presence of binocular diplopia, double vision, could indicate various conditions such as myasthenia gravis, a neuromuscular disorder, thyroid ophthalmopathy, or intranuclear ophthalmoplegia, a condition affecting the nerve pathways within the brainstem. 5. The trigeminal nerve, a symphony of sensory and motor functions. The trigeminal nerve, the fifth cranial nerve, is a powerhouse of sensory and motor functions. Its 3 branches, the ophthalmic, maxillary, and mandibular, play crucial roles in sensation, facial muscle control, and even the corneal reflex. Let's first explore the motor functions of the trigeminal nerve. We'll ask the patient to bite down on a tongue blade while we palpate the temporalis and masseter muscles, which control chewing. Then, we'll attempt to remove the tongue blade from their mouth, asking them to resist. Finally, we'll ask the patient to deviate their mandible against our resistance bilaterally. Here's what we're looking for: any asymmetry in the contraction of these muscles, an inability to secure the tongue blade in the mouth, or any weakness in mandibular deviation could indicate a trigeminal nerve problem. A unilateral weakness might indicate a pontine lesion affecting the trigeminal nerve, while bilateral weakness could suggest bilateral hemispheric disease, such as a stroke. Now, let's delve into the sensory side of the trigeminal nerve. After demonstrating the stimuli, sharp and dull, on an area of the body not being tested, we'll apply these stimuli to the forehead, cheeks, and mandible on both sides. We'll then use a fine wisp of cotton, asking the patient to point to where they feel the sensation. Any hyposensitivity to these stimuli, whether affecting the entire side of the face, a specific area, or both sides, can be a red flag. For instance, hyposensitivity on the entire right side of the face, compared to the left, might indicate a right trigeminal nerve lesion, potentially caused by trigeminal neuralgia. Hyposensitivity at only the forehead, cheek, or jaw on the right suggests a lesion affecting the ophthalmic, maxillary, or mandibular division of the nerve, respectively. 6. Corneal reflex, a protective blink. The corneal reflex, a rapid, involuntary blinking response to a light touch on the cornea, the outer layer of the eye, is a powerful protective mechanism. This reflex is a collaborative effort between the trigeminal nerve, carrying the sensory input from the cornea, and the facial nerve, which sends the motor command to blink. To assess this reflex, we'll ask the patient to look away from the side being tested and lightly touch the cornea, not the sclera or conjunctiva, with a fine wisp of cotton. We'll perform this bilaterally, testing the involved side last. If the patient is apprehensive, gently touching the conjunctiva first might help ease their concerns. An absent blink response in one or both eyes could point towards a problem with the trigeminal or facial nerve. For example, if we touch the right cornea and neither eye blinks, it suggests a right-sided trigeminal nerve lesion affecting the ophthalmic branch. If only the right eye blinks, it might indicate a left-sided facial nerve lesion. And if only the left eye blinks, it could suggest a right-sided facial nerve lesion. An absent blink response in combination with sensory neural hearing loss, a condition affecting the inner ear and the auditory nerve, might indicate an acoustic neuroma, a benign tumor affecting the vestibulocochlear nerve. 7. The facial nerve, the artist of facial expressions. The facial nerve, the seventh cranial nerve, is the maestro of our facial expressions, controlling the muscles that allow us to smile, frown, raise our eyebrows, and close our eyes. It also plays a role in taste sensation and tear production. To assess the facial nerve, we'll ask the patient to perform a series of facial expressions, raising both eyebrows, frowning, closing both eyes tightly, showing their upper and lower teeth, smiling, and puffing out their cheeks. We'll be observing for any asymmetry in muscle contraction, particularly when the patient smiles or grimaces. A drooping on both the upper and lower face might suggest a peripheral injury to the facial nerve, such as Bell's palsy, a temporary paralysis of the facial muscles. On the other hand, drooping on only the lower face might indicate a central lesion affecting the facial nerve, potentially caused by a stroke or transient ischemic attack, TIA. Bell's palsy can also present with other symptoms, including ageusia, a loss of taste, hyperacusis, an increased sensitivity to sound, and an increase or decrease in lacrimation, tear production. 8. The vestibulocochlear nerve, the symphony of sound and balance. The vestibulocochlear nerve, the eighth cranial nerve, plays a crucial role in hearing and balance. It comprises two distinct branches, the cochlear nerve, responsible for hearing, and the vestibular nerve, responsible for balance. We'll be assessing the cochlear nerve function through two classic tests, the Weber and Wren tests. The Weber test, a battle of sound. For the Weber test, we'll use a 256 Hz or 512 Hz tuning fork. After demonstrating the sound of the fork, we'll set it into vibration and place the base firmly on top of the patient's head or on the mid-forehead. We'll then ask the patient if they hear the sound better in one ear or if it's equal in both ears. The sound lateralizing to one ear, meaning the patient hears it better in one ear, indicates an abnormal finding. However, it's important to remember that patients with bilateral sensory neural or conductive hearing loss might have a negative or normal test, or even say, "I don't hear anything." Here's how to interpret the Weber test findings. Lateralization to the side of hearing deficit. This indicates conductive hearing loss, a problem with the outer or middle ear impairing sound conduction to the inner ear. Possible causes include foreign bodies, otitis media, a perforated tympanic membrane, or otosclerosis of the ossicles, the tiny bones in the middle ear. Lateralization to the opposite side of hearing deficit. This indicates sensory neural hearing loss, a problem with the inner ear, the cochlear nerve, or the neuronal impulse transmission to the brain. This could be caused by loud noise exposure, inner ear infections, Meniere's disease, an acoustic neuroma, congenital or familial disorders, or the natural aging process, known as presbycusis. The Wren test, air versus bone conduction. Next, we'll perform the Wren test. Using a vibrating 512 Hz tuning fork, we'll place the base against the patient's mastoid process, the bone behind the ear, until they can no longer hear the sound. This measures bone conduction. Then, we'll quickly move the vibrating fork close to the ear, still facing the patient, until they can no longer hear the sound. This measures air conduction. We'll repeat this process bilaterally, beginning with the uninvolved side first. Here's how to interpret the Wren test findings. Normal test. Air conduction time is greater than bone conduction time, which is considered a Wren positive result. Abnormal test. Bone conduction time is equal to or greater than air conduction time, which is considered a Wren negative result. Alternatively, the test may be abnormal if there is a significantly decreased air conduction time and bone conduction time on the impaired ear compared to the other. Here's how we connect these findings to hearing loss. BC greater than equals AC, Wren negative. This indicates conductive hearing loss. Decreased AC and decreased BC, AC still greater than BC. This indicates sensory neural hearing loss. 9. The glossopharyngeal and vagus nerves, guardians of swallowing and speech. The glossopharyngeal, 9, and vagus nerves, the 9th and 10th cranial nerves, are the silent heroes behind our ability to swallow, speak, and even sense taste. To test these nerves, we'll use a sterile tongue blade and a light source to depress the patient's tongue and gently contact the posterior pharyngeal arches, one at a time, and then bilaterally. This stimulates the sensory component of the glossopharyngeal nerve. We'll then observe for the elevation of the tongue, soft palate, and constriction of the pharyngeal muscles, which are controlled by the motor component of the vagus nerve. A diminished gag reflex is a common finding in healthy individuals, so it's crucial not to jump to conclusions. However, an absent pharyngeal contraction on one side or both can indicate a problem with these nerves. For example, if we contact the left posterior arch and there is no reaction bilaterally, it suggests a left-sided glossopharyngeal nerve lesion. If only the right side contracts, it could indicate a left-sided vagus nerve lesion. And if only the left side contracts, it could point towards a right-sided vagus nerve lesion. 10. The vagus nerve, the test. Another way to assess the vagus nerve is through the test. We'll ask the patient to open their mouth and say, or yawn, while we observe the back of their throat. As the patient performs this simple maneuver, we'll look for the elevation of the tongue, soft palate, and uvula. If the soft palate fails to rise on one side, causing the uvula to deviate to the opposite side, it's a sign of a possible vagus nerve dysfunction. For example, if the uvula deviates to the right, it suggests a left-sided vagus nerve lesion. Conversely, if the uvula deviates to the left, it indicates a right-sided vagus nerve lesion. It's important to note that we must ensure the patient's uvula isn't already deviated before they say, This ensures we don't misinterpret a pre-existing condition as a vagus nerve issue. 11. The spinal accessory nerve, shoulder power and neck rotation. The spinal accessory nerve, the 11th cranial nerve, is the powerhouse behind the sternocleidomastoid and trapezius muscles, responsible for neck movement and shoulder elevation. To test this nerve, we'll first visually inspect the patient's trapezius muscles from behind, looking for any signs of atrophy or fasciculations, involuntary muscle twitching. Then, we'll ask the patient to shrug their shoulders upward against our resistance, holding the position for 5 seconds on each side. Next, we'll passively shorten the patient's sternocleidomastoid muscle by laterally flexing and rotating their head. We'll then try to reposition their head back to a neutral position while they resist, holding for 5 seconds on each side. We're looking for any signs of muscle weakness, where the patient can't generate the expected force, or pain upon resisted muscle testing. For instance, weakness on both the sternocleidomastoid and trapezius on the right side could indicate a right-sided spinal accessory nerve lesion. Similarly, weakness on both muscles on the left side points to a left-sided lesion. However, weakness and pain specifically in the trapezius muscle on one side might simply indicate a muscle spasm or sprain rather than a nerve issue. Remember, a supine patient with bilateral sternocleidomastoid weakness will have difficulty raising their head off the pillow, which can be a clue to a more widespread neurological problem. 12. The hypoglossal nerve, the tongue's maestro. The hypoglossal nerve, the 12th cranial nerve, controls the muscles of the tongue, allowing us to speak, swallow, and even taste. To assess this nerve, we'll first visually inspect the patient's tongue for any signs of atrophy or fasciculations. Then, we'll ask the patient to slowly protrude their tongue outwards as far as they can, observing for any asymmetry, atrophy, or deviation from the midline. Next, we'll ask the patient to push their tongue into their cheek while we try to press it back, holding for 5 seconds on each side. Here's what we're looking for. Atrophy or fasciculations. These can be signs of conditions like amyotrophic lateral sclerosis, ALS, or polio. Deviation of the tongue. If the tongue deviates to the right, it suggests a right-sided hypoglossal nerve lesion. Deviation to the left indicates a left-sided lesion. Weakness. If the patient demonstrates weakness on the involved side compared to the other, it further supports a hypoglossal nerve lesion. Wrapping up our cranial nerve journey. And there you have it, a comprehensive guide to cranial nerve examination.